Good afternoon. Of course, always a pleasure to be here in the beautiful city of Trivandrum. And usually I always start by thanking the organizers. But somehow at JPEF, I don't think I need to thank because I somehow feel like I'm part of JPEF. So by default, you just feel this conference is so special to me that the organizers are so special to me that I just feel like I'm part of it. And of course, like Georgie sir was introducing me, my picture is up there. 2019 was when I got the very prestigious JPEF award as well. So this conference is extremely special to me. I bring greetings from Chennai, and this session is, like Krishna Sheshadri sir was saying, extremely special, extra special, because I have the honor of sharing the stage with not one, but two of my teachers today. And one, of course, Krishna sir was saying that I always tell him about that image I have of him on my first day of MBBS when he walked into the room. He mentioned that, yes, he walked into the room with a cup of coffee in one hand and an apple in the other, munching on an apple. What he did not mention is how he came in with style. And of course, Dr. Georgie sir, I have no words. He is beyond just a teacher to me. He is like a father to me. And I've been with him right through my MBBS, and I was his postgraduate during my MD days. He's been my guide, my mentor. Like I said, I have no words to describe him and thank him. All I can say is I'm blessed, fortunate, and proud to be his student. And like Krishna sir was saying, one of the anecdotes is, I think what I've learned from him more than, of course, the science and the nephrology and medicine from him, or academics, what I've learned is empathy and no excuse when it comes to treating patients. I remember the number of times that as postgraduates, when we're standing there, we'll be shivering to say, sir, patient is not affordable, because that is not an excuse. I remember the number of times he's reached into his wallet to pay for the patient's treatment himself. And of course, the Tanka Foundation that provides free dialysis for patients in Tamil Nadu is testament to that. Yes, having said that, thank you also for Buringer, I think I should mention here, for being part of the session. So we heard about the previous session from Krishna sir about the renal benefits of the SGLT2 inhibitors. What I'm going to be addressing in the next couple of minutes is the role of combination therapy of the SGLT2 and the DPP4 inhibitors in patients with type 2 diabetes. This is my financial disclosure. I want to start off, because we're all clinicians at the end of the day, so it's always nice to start off with a case study, because it's something that sort of sticks with us, and we can take it back to our clinic when we go back to our clinic on Monday morning. So this is a typical case scenario. A young individual, 35-year-old, who's been recently detected with type 2 diabetes, and he's also a known case of dyslipidemia. He has a sedentary lifestyle. For his diabetes management, he's currently only on metformin, 2 grams a day. His BMI is high, blood pressure is under control, and while on metformin now, his HbA1c is still deranged, 8.5, fasting and postprandial is also high, so some action needs to be taken. His lipids are also deranged. His ultrasound reveals that he has fatty liver. Renal status is primarily normal, and liver function is also normal. So what is talking over here, I think the most obvious, not obvious, but the most striking fact over here is that a young individual at the age of 35 is diagnosed with type 2 diabetes. And this is something I think we have all become so used to seeing in our clinics every day. But the fact being that, yes, in India, the age of onset of type 2 diabetes is much lower, and we know this for a fact. It is much lower as compared to the Caucasian population. In context to that, this is a publication we just published last month. As you can see, I've highlighted the publication date in the Journal of Diabetes, just published a month ago. And this is data from our STRIDE study from Tamil Nadu, where we published the rising prevalence of type 2 diabetes in our part of the world. And an analysis of this, we actually split the group as less than 40 years of age and above 40. And as you can see, the numbers may look small to you. However, as you can see, above 40, the number is 28%. So this is data, sorry, I need to highlight here. This is data comparing a 10-year rise after 10 years from 2006 versus 2016, the prevalence of type 2 diabetes in Tamil Nadu, in both the rural as well as the urban population. So as you can see, we've split the population as less than 40 and more than 40, and although the number of the age less than 40, 4.5% in 2006 versus 8% in 2016, although that looks small, you can see in the graph on the right that, is there a pointer that I can use?
Another pointer. Red.
The red one? The green? Ah, right. So got it. Thank you. So as you can see, although these numbers look small, you can see when we look at the percentage of increase in people less than 40, the striking number is almost a 70% increase in our younger population. And why is this important? The reason being, the younger you are, these patients are at diagnosis, the longer they're going to be living with type 2 diabetes and the longer they're exposed to the ill effects of hyperglycemia. In other words, their risk of complications is also going to be higher. So this is something that is very worrisome, and on further analysis we also found that prevalence of obesity is also on the rise. There is a significant increase in the prevalence of overall obesity and also waist circumference, which I'm not showing you here today. There is also a significant increase in the dyslipidemia among subjects less than, and this is again in the group age less than 45. This is our own Indian data just published last month. So that as a context, this is another typical patient. This is a 55-year-old lady who is now type 2 diabetic since 2 years, also known case of hypertension and dyslipidemia. Her BMI is also high, blood pressure is okay. She's HbA1c is currently 8.1%, currently only on metformin again. She's on a statin, she's also on an ARB, amlodipine, and her lipids are okay. However, as you can see, she has some amount of renal. So you have an eGFR of 60 and she also has some amount of albuminuria. So these are two typical cases. Now this is a background. I'm going to now move on to what next. Now, and also I think the previous, so this lady also on echo shows diastolic dysfunction. Now this is data to show you, I think as clinicians we see this quite often, isn't it? But we most commonly dismissed it because most of these patients with diabetes that we see in the clinic are asymptomatic. However, a routine echo or an incidental echo will reveal that they have grade 1 diastolic dysfunction, isn't it? We see this so commonly in our clinic. And this is data to show us that almost 50% of patients with type 2 diabetes do have some amount of LV diastolic dysfunction. This is also again South Indian data from Dr. Vijay Vishwanathan, in which he has actually shown, this is the same table that Krishna sir had shown you, in which the percentage of people who are in this category, that is people with normal kidney function, is a mere 30% or almost 30 to 40%. In other words, more than 60% of our patients with type 2 diabetes have some amount of kidney disease. So what do we do about this? Now I presented to you two cases. One was a very young individual with type 2 diabetes, newly detected on metformin uncontrolled. The other was an older lady with prior history of complications. She now already has LV failure and she's also on metformin and out of control. So some action does need to be taken. So what are our priorities when we have a patient sitting across the table with us? What are our priorities as clinicians in these patients? And the priority is, as we all know, like we heard from the brief, our approach to such patients has actually moved from earlier from a glucose-centric approach to a more individualized approach, number one. And what that means is we want to not just reduce the blood glucose, but we want to do so with many other tick marks. One, we want to reduce the blood glucose with a lower risk of hypoglycemia. Number two, there is no excuse today as clinicians if we do not use agents that are going to reduce the risk of complications in our patients. Because today we have agents that have proven to do that. Last but not the least, we also want extra glycemic benefits like maybe weight loss or if possible at least weight neutral. We also want to reduce the treatment burden or the pill burden because we know that diabetes is a chronic disorder and we don't want to burden our patients with too many tablets or a polypharmacy either. So when we combine a DPP4 inhibitor with an SGLT2, we get the so-called synergistic benefits that both offer. And this table here actually summarizes that the DPP4 inhibitors provide glycemic control with the lower risk because of their glucose-dependent action. They're basically secretagogues but with the glucose dependent action and does have a lower risk of hypoglycemia, very well tolerated. Their cardiovascular and renal safety has also been proven. SGLT2 inhibitors, because of their insulin independent action, of course, good glycemic control without the risk of hypoglycemia, cardiovascular and renal safety has also been proven. I think I'll skip this slide, but just to summarize here is that, excuse me, on the background of metformin, when we add SGLT2 with the DPP4, we sort of cover almost all pathophysiological features. And what we do get to achieve is good glycemic control, which is also sustainable. The SGLT2 inhibitors are quite powerful agents. They do reduce the blood glucose even on, I think they're getting, even on day 1 or day, thank you. And this is something that we see in our inpatients, because this you may not see in the OPD. Excuse me. I have a bad throat for the past couple of days. But yes, when you, this is something you do quite commonly see in the inpatients. When you initiate an SGLT2, by day 2 or day 3 itself, you find that drop in the blood glucose, because it sort of breaks that glucotoxicity. Especially because, as I mentioned earlier, it has an action independent of insulin and works through the renal passage. And as a result, you see results very quickly in terms of reduction of that blood glucose, and that's what this data is showing you. At baseline, 195 reduction by around 30 milligrams by day 2, and by day 14 beyond that. And this in turn translates to improvement in beta cell function and also improvement in sensitivity as well. This is data to show us that also SGLT2 inhibitors reduce glycemic variability, and this is basically CGM data showing us the time and range is better with empagliflozin 25. But I think one of the points here to remember is, and I think many of you might probably see this, SGLT2 inhibitors are being unique in their action, can be used at almost every stage in type 2 diabetes, even in patients who are insulin dependent. And like you heard from, like Krishna sir was saying, as long as the eGFR is good and sufficient, their action is very, very potent. And we found that even in patients on very high doses of insulin, it actually helps to reduce the glycemic variability, reduce the risk of hypoglycemia, and even reduce the insulin requirement. Not COVID, don't worry. Yeah, so adding on an SGLT2 on a background of metformin, you get comparable results in terms of HbA1c reduction. But last but not the least, you also, beyond glycemic control, you also will get weight reduction. This is something we all know. Beyond weight reduction, if you remember, this patient had fatty liver, and this is a slide to show, this is data to show you that there is also a reduction in the liver fat and intravisceral adipose tissue, which is also a beneficial effect. This is the summary of all the CVOTs. This is embarrassing. Never happened before. And I think the more I talk, the more it's irritating my larynx.
No worry about it. So this we've talked about before, right? Look at what is happening. The MACE, the CV death, the all-cause mortality, hospitalization, very chronic. It's also important to understand how these drugs work out. Remember, the EMPEREC was done on a high-risk group, benefit. Canvas, high-risk group, benefit. Declatomy, not a high-risk group, no benefit. Good?
Thank you. Thank you. Always great to get your teacher to fill in, isn't it? Yeah, so I think one of the points that I'd like to actually highlight here, sir already very nicely explained this particular slide, but the renal benefit. See, the EMPA-REG, the Canvas, the DECLARE, all these Averta CV, all these trials were cardiovascular outcome trials which proved cardiovascular benefit beyond doubt, right? These trials also showed in the secondary outcomes, they also showed renal benefit. However, the renal benefit that all these trials showed were in baseline of patients with higher EGFR and with or without proteinuria, right? The trials later on, the dedicated renal trials, like the CRIDENS, which also Sir discussed, the CRIDENS and the DAPA-CKD and what was the EMPA kidney trial, took it one step further and lowered the EGFR, and they were daring enough to even try it out in patients without type 2 diabetes and actually prove the renal benefit beyond glycemic status, right? So now you know that these drugs, the benefit that you see in terms of kidney protection is beyond just the blood glucose, because the benefit is also at a lower EGFR and in patients with or without type 2 diabetes. So that is one of the points that I wanted to bring to light. And like what Sir was saying, as long as your EGFR is preserved and if you have a good EGFR, you get good glycemic control. If you have a patient with a lower EGFR, it's still worth continuing the drug, because even at low EGFR, across the spectrum of renal disease, you have renal protection. So you probably need to add on another agent to achieve glycemic control, but it is worth continuing the SGLT2 inhibitors. This is a snapshot of the DPP4 inhibitors. Of course, this is like, history. I think we know this is like a snapshot of 20 years ago or 15 years ago, where the saber-to-me was the first CVOT that came out with saxagliptin with the DPP4 inhibitors, raised a small signal about increased risk of heart failure, and that question was then answered by the TCOS trial with sitagliptin, no signal of heart failure, and put that question to rest. The Carmelina was the CVOT dedicated with linagliptin that actually showed a small reduction in the risk of heart failure with linagliptin, although not statistically significant. But a summary of this is that all the CVOTs with the DPP4 inhibitors have proven the cardiovascular safety of these group as a class. The Carmelina, also the icing on the cake, was that an unexpected outcome was that they actually found renal benefit with linagliptin. There was a significant reduction in albuminuria with linagliptin in the trial. So, to summarize what we've just looked at in the previous part of the so far, when we combine an SGLT2 like empagliflozin with linagliptin, you get benefit beyond glycemic control, and you get the synergistic effect of both put together. And when you add this on a background of metformin, you are also reducing not just glycemic control, but you're also reducing the risk of complications. So the benefit that you get when you add on an SGLT2 inhibitor is that you get good glycemic control, weight loss, cardiovascular protection, reduced risk of heart failure, as well as improvements in renal status. When we combine that with a DPP4 inhibitor, furthermore, you are also enhancing the glucose-dependent insulin secretion, achieving targets without the risk of hypoglycemia. Last but not the least, very well tolerated. And with a DPP4 like linagliptin, of course, we know that there is no need for dose adjustments even in patients with chronic kidney disease. So in summary, I think we are now in an era where management of type 2 diabetes has actually evolved, and our approach to a patient with type 2 diabetes is beyond just the blood glucose. We need to be using the right agents to achieve targets, and like I showed you data, when we have younger patients being diagnosed with diabetes at a younger age, it is our responsibility as clinicians to ensure that we reduce the risk of complications. And today we have agents to help accomplish that. And when we have an FDC like an EMPA-LINA combination, adding that on a background of metformin actually helps to also reduce the pill burden and achieve targets in our patients. Thank you.
Thank you, Nanditha. Please join me here. In the interest of time, we may take 3 questions from the floor and some comments. Please.
In CKD, there is no established role for Arun. However, if you take the second patient here, you will see that even though her, I want to use this to bring a point about heart failure in women. The indices of heart failure in women, right, as well as the criteria to start medications are actually different. Because there are sex differences in the echo, right? Now, this patient, we didn't have the data, but when I would have seen this, if for example the NT-proBNP is elevated, I would have calculated left ventricular mass index, left ventricular volume index, and seen if that was also altered. If these were altered, irrespective of the ejection fraction, this patient I would have shifted from an ARB to an RB, because that was the data that is in women especially. In a man, it's still largely EF driven, so you would not do it with unless it's less than 55. But in a woman, irrespective of the EF, right, with other criteria present, I would switch. So there is a data. In CKD, I know Georgie wants to comment, not much of an experience.
No, I think Jacob George has done a study and published from Toronto Medical College.
Jacob has done a study, but my only concern is that as there is a progressive decline in DFR, potassium issue problems.
No, that should be always monitored.
No, because I see in my practice, because those who are on ANI come with severe hyperkalemia, we have to admit them, we have to give them medications to lower the potassium, which doesn't happen with SGLT2 inhibitors.
See, also, I think in the renal space, I think the MRAs have better data than RDs, so we need to be careful.
What about the combination of GLP plus SGLT2?
So we were talking spouse things this morning. I think this is really a marriage made in heaven. There's no other question.
No, I think Dr. Nanditha, I think you should emphasize the point that this combination has become generic. So I think it should be rampantly used. Empagliflozin plus linagliptin should be rampantly used. Because earlier it was cost 78 rupees for glycine. Now it is come to the floor. So everyone should use this. Maybe as you said with metformin.
Absolutely. Agree with you, sir.
And again, I think this combination, I think it also blocks the DPP4 enzyme activity of the bacteria or the fungus.
So reduce the stress of GI, genital urinary.
And reduces the genital
Urinary, yes.
As there are no further questions, I think we should close the session. I thank you all for actively participating, and also my colleagues Krishna Sheshadri. And I forgot to say that Nanditha, I'm very proud that 6 of my students are now MRCP examiners with me, and among one of them is Nanditha.
Thank you so much, chairs and speakers, for the wonderful session. Now moving to the much awaited session, that is the Twin Talk, an update on all the latest technologies in diabetes care. And the theme is It's Different at 12, Bridging the Gap in Diabetes Technologies.